आपने एम्स में काम किया, then you went to US, but you came back and you worked in Gangaram. Sir, what's the difference?
So one of the struggles I had at Gangaram was there was an oncology practice there, but there wasn't an oncology department being driven, and there was no radiation. That's such a key thing for head and neck.
So now probably you don't absolutely need to go to US for the fellowships.
I don't think so. I mean, if you need to get trained in head neck, India is good. There are excellent institutes offer great training.
So talking about cancer phobias, what exactly do you screen them for? How do you screen them for, and what do you tell them?
We do get patients who are convinced they have cancer.
Right.
Often they have a little bit of tobacco intake. They're very difficult patients. Very.
You came back from US. Now tell me about it. Why did you come back?
So when we came back, I think when we left, we kind of had this thing, we're going for 2 years, we're going to come back. And like a horse with blinders, we just refused to look left or right and said, Vapas jana.
Hello everyone, welcome to Delhi Docs, जहाँ white coat सिर्फ कहानी की शुरुआत है. Our today's guest is the Vice Chairman of Head and Neck Oncosurgery in Medanta. He has been trained from AIIMS Delhi. Then he went to USA for a fellowship, and then he came back and established departments, especially in New Delhi. He's none other than Dr. Deepak Sarin. Today we have talked about the subtle nuances of being a surgeon, the glory, the grief that comes with it, the long working hours, the mindset that goes into each surgery, the dealing with death, bad news, and triumphs after a successful case. So let's quickly dive into the podcast and welcome Dr. Deepak Sarin. Thank you, sir. Thank you for coming to the podcast.
My pleasure.
Sir, I'll straight away ask about your journey. You did your MBBS from AIIMS Delhi. You did your MS from AIIMS Delhi. You did SRship in AIIMS Delhi. Sir, do you think these degrees from the best institute in this country, do they matter still? How did it affect your career?
So I think, I don't know if the degrees per se matter, but I think what you get when you train in a place, it matters. I mean, I'm a head and neck surgeon today, but I think my journey to head and neck started only because I was exposed to it well during my training. And the fear of dealing with cancer went away. More than the degrees, I think the culture of a place. So every institute carries its own culture. And if your institute's culture is just try to be the best you can at what you are, then you just imbibe that culture. It's true for you look at countries, societies, you imbibe the culture of where you are. यहाँ हम लाइन तोड़ते हैं, हम US जाके सेटल होते हैं, लाइन में खड़े होते हैं. You imbibe the culture of wherever you are. It's just natural. So I don't know if it's necessarily the degree or the stamp, but it's the culture or the training that I think matters a lot.
Sir, आपने AIIMS में काम किया, then you went to US, but you came back and you worked in Gangaram. You set up a department. You are now the head of the department for head and neck surgery in Medanta. You've also worked in AIIMS. So, these are many corporate hospitals and government hospitals. Sir, what's the difference you feel in the, let's say, in the work quality or the training, or what do you have to say about the differences?
So I guess in some ways I was fortunate. When I trained in head neck and came back to India, it wasn't a recognized field. In fact, head neck people thought I deal with spine. So I would get calls, consults for sir mein dard hai, aapko dikhana hai. Head neck as a specialty was not recognized. People really don't know what head neck is.
Sir, which year are we talking about?
We're talking 20 years ago, 2005.
Okay.
So I got very lucky that I got an opportunity to join Gangaram, which was a very well-established hospital, and start a department. So I could actually just practice my niche. That was a big break, I think. And I had tremendous support from the Department of ENT. They sort of took me in like I'm a family member. And because my training was good and the work was good, from the hospital I got a lot of support. So because it's, you think there are 500 doctors there. They have 50,000 patients under their care. That's a very large referral base. If they believe you take good care of patients, that's a very large referral base to start with. So I think I was lucky with the first break I got. The struggle was with trying to tell people what you do. As a head neck, it took a long time for people to recognize that there is a subspecialty called head neck and there is somebody who's niche trained in this area. Because everybody already has their referral pathway set. Even before somebody like me comes in, People were getting treated by good doctors. See,
But in which field?
I think a lot of head and neck was dominated by surgical oncology.
Okay.
Head and neck has expanded a lot. So thyroid is very much our baby now. But a lot of thyroid 20 years ago was general surgery domain. When we were trained in thyroid by general surgery. Still is, I think, around the country. But so people really don't know what you do. And everybody's got, like if Dr. A thinks, I have somebody who's got a thyroid lump, they're like, I send it to a general surgeon. They've been taking good care of the patients. They need a very good reason to change and send to you. Like you have to be or show that you can provide 1-2 notches care above. Because they have established referral lines that they trust for 20 years. They need a good reason to break it. They need a really good reason to break it. So it took a while, but I was very well supported by the hospital. I think I'm very grateful for that once it was recognized what I do and what I can, and the results were good, they supported. Like I got a lot of intra-hospital referrals. In fact, pretty much my practice built from intra-hospital referrals, and being in Gangaram, which has such a big patient base and such well-reputed doctors at that time, it really helped.
Then how many years did you work there, sir?
So I was there 2 years, 2005 to 7. And 7, Artemis started. And when Artemis started, so one of the struggles I had at Gangaram was there was an oncology practice there, but there wasn't an oncology department being driven. And there was no radiation. That's such a key thing for head and neck. So PET scans had come in at that time. So Artemis started at that time with a very good oncology setup. Top-end radiation machine, PET scanner, like everything that you need to build an oncology department, and very good people joining. So I actually moved to Artemis in 2007. It was a big leap of faith. Us samay, there was no NH8 like you see today. There was the old highway. There was no road to reach Artemis. It was a bumpy stone pathway. There was no tarred road. And then I took a house like where I stay now, which is another kilometer beyond Artemis. And as my sister said, if you need to get to your house, you need to go to end of the world and then go another 50 kilometers and we reach your house. So it was a big leap of faith, but it turned out well. It turned out really good. I was able to start the department there. It was slow growth, but it turned out well. I had again gifted with very good colleagues, and that helps a lot. And oncology particularly, if you have a good team, good colleagues, it really helps a lot.
And then, sir, the shift to Medanta?
That. Again, leap of faith. Medanta was coming up, and the size of Medanta was huge. Every time you drove by, you see this behemoth of a building in front of you whose shadow is all over. I think what tempted me to Medanta was they imbibed terrific faculty when they started off. They got really, really good people. And one of the great pleasures of working in Medanta, and I think working in general, is you have very nice colleagues. That's a great pleasure of working. So again, a leap of faith. I was very comfortable in Artemis. It was good. But I felt if I have to grow a department of head and neck, I need a bigger platform. See, head and neck is a niche area. A 200, 250 bedded hospital can support maybe one head and neck surgeon. It's unlikely to generate volume enough to support more than one. If you need to build a department, and that's how everybody eventually wants to work as part of a department.
Especially the surgical.
You need
teams.
a bigger volume center. And I think Medanta offered that kind of infrastructure. And I knew so many of the faculty who were joining, and a lot of them came from Gangaram, and they were all very, very top end in their field. So that was the reason. I thought a bigger platform, chance to develop a department, grow it, and we managed that. So I'm happy to say we are now a 10-person head and neck department. There are very few private institutes that can have a 10-person department. We have 4 consultants, training program, 6 fellows. So yeah, so every move was good. I tell young people who are looking for who are also thinking moving and what. And I'm like, generally all change is for the better. Like, don't be too scared. Just take a leap of faith. Most change is for the better.
Sir, you spent your formative years in AIIMS. It never occurred to you that maybe I should go back to AIIMS?
Oh, always. Oh, a lot. So my career path is also a bit of coincidence. So hota hai, everybody has coincidence in their life. I grew up on AIIMS campus. My mom was faculty there. I pretty much grew up on the campus, joined MBBS there. I had pretty much lived my life. And with parents as faculty, and my uncle was head of department of surgery there, I thought this is my life. Like, I'm going to I actually wanted to be faculty at AIIMS. But when I finished I was, I guess, around 30 or so when I finished training at AIIMS. And, but when I finished, there was no job vacancy there. And it was a big shock. You know, you're a senior resident in ENT and the world is clamoring to try and see you, and outside your OPD there are 50 patients falling over each other. You feel like you're the center of the universe. And April 4th your job finishes. April 5th nobody wants you. Nobody cares who you are. You walk into the department, they're like, good morning, but you really have no role. There's not a single patient who wants to see you anymore. It was a big shock when I finished. The next day was like a shock. They're like, you get up in the morning, you get ready, and there's nowhere to go. And I actually didn't have a job for a while. So it was hard. And I had a small kid at that time. So it was hard, no job. You felt fairly worthless and useless. At that point, I thought, to find purpose, I was like, let me go get training. So I took the USMLE post my senior residency. I studied MBBS books again.
Oh. Sir, which year was this now?
This is 2001. 2002. Sorry, 2002 I decided. I passed MBBS in 95. So 7 years after MBBS, I thought, let me go super specialize. And I read for the USMLE and I applied in the US, and I thought, let me go for training. So yeah, sometimes, and then my career path became a head and neck surgeon after training. If I'd been AIIMS faculty, I might have been in some other job and hopefully enjoyed it as much. But so that's life, Sometimes it's just some circumstances direct your life more than your great planning.
And sir, in US, how was the experience in US?
Tremendous. Some of the best years of my life.
Was it like you were assisting more or seeing more, or were you actually able to do something? Was it like...
No, this was a clinical hands-on fellowship, like a fellow at par with an American fellow. No different. They took 2 fellows every year in the department. One was domestic candidate, one was international. You had to take the USMLE, and you had a license to practice in the university. So you were operating just like a fellow, absolutely at par, pay scales at par. Wonderful fellowship. We had, my wife and I think, some of the best years of our life there. It was insanely crazy. The day would start at 5 o'clock. Like, I would normally leave home before 5. OR started at 7. You had to round before it. And in head neck, a 10, 12, 14-hour operation is not unusual. You would finish at 11 in the night. You would come home at 12 or so, get 4 hours of sleep, go back. But the one thing so it was very, very heavy, like labor intensive, very, very heavy. But the weekends were off. So Friday evening, 5 p.m., that was the pager age. There was no cell phones. 5 p.m., you turn your pager off. It goes to the on-call resident. And you only turn your pager on at Monday, 6 o'clock in the morning.
Oh, wow.
And even though you have to do your own stuff a lot in the US, you could generally wrap up all housework in half a day. So Saturday first half, you're done with your shopping, your cleaning, your laundry, whatever else chores you need to do around the house. You have like a day and a half free. So the free time was thoroughly enjoyed. Work days were very busy though. But the free time was thoroughly enjoyed. Sometimes you don't get that here. Even free time is almost never your own.
Yeah, even... Sir, how do you deal with the messages? And it's a bit off-track question, I'm sorry, but how do you deal with patients messaging you at odd hours or calling you up?
I fluctuate.
Okay.
Sometimes I feel I don't need to respond to a message. And then sometimes you think from a patient's point of view, they just need a little guidance. And so there'll be weeks I'll reply to every WhatsApp. And there are weeks there where I will generally message, have an appointment, see me. let me decide. It fluctuates. I guess it depends on how your life is going. If life is really hectic, you're probably less responsive to WhatsApp messages. And if life is a little free and you think you have guidance. See, one of the things with WhatsApp messages I'm hesitant about, and I think, I don't know how others feel, is you don't always get the right information in a message. And you're really concerned you'll misguide somebody. That's a genuine concern. I think there are legal ramifications also, but take them apart right now. Sometimes, you just don't have the patient's written the right picture to you. And you are trying to tell them, no, this is okay. And tomorrow something happens and you feel like, it wasn't judged well. It's different when you see the same patient in clinic and you sometimes, we make judgment calls all the time. Sometimes they're right, sometimes they're wrong. You see a wound and the patient thinks there's more pain and swelling, for example, and you're wondering, is this wound infected? And you take a look and you examine and you think it's probably not. But you've spent 15 minutes seeing the patient, you've spoken to them and you tell them, look, I think it's not. It'll probably be okay. If something changes, come back, I'll relook. That same message can never be conveyed over WhatsApp, where it feels like you're brushing them off. Like if I think things are okay and I say, no, it looks okay. If something worsens, see me. And something does worsen. It does feel, I think in retrospect, people may think that you brushed them off the first time. So I sometimes feel WhatsApp consults are, slippery ground, I think. But then I also think if not me, who's going to guide them? Like maybe they just need guidance. If not me, then who will guide?
Absolutely, sir. And sir, now coming back to our same track of questions, you came back from US. Now tell me about it. Why did you come back? How did you feel on coming back? Are there still some regrets?
Coming back, as I used to say, temporary insanity. But so it was very difficult to readjust. The first couple of years were very tough. As I said, we had a great time there. My wife also trained as a cytopathologist. She had an offer to just, they were going to waive off a couple of years of her residency. I said, just do a year of residency and we'll take you in. I had job offers, people willing to fly you down to cities and see the practice and think if you want to join. So when we came back, I think, when we left, we kind of had this thing, we're going for 2 years, we're going to come back. And like a horse with blinders, we just refused to look left or right and said, Vapas jana hai. That's what we just didn't let that waver. So I think we just moved back. Also, I think probably some family reasons also. My parents are Delhi, my wife's parents are Delhi based. My sister's already settled in the US by that time. My wife's sister was settled in the US. So the only siblings was for us. And then parents were in the same town. So it may make lesser sense if you return to Delhi, but your parents are in Chennai or Calcutta. Then you may not be there for them. Distance is still quite a bit. But with them being in the same city, it did feel like if we are back, then it would be better for them. So I think that was there as well. But it was tough to come back. When we came back, those were the days जब बिजली 8-8 घंटे जाती थी. आजकल तो कम होता है ऐसे. So we moved back to our parents' house in Noida, sleeping at night and, jet lagged anyway. You're not able to sleep till 3 or 4 in the morning. 5 बजे की तरह आँख लगी. The lights had been out since 12 in the night and inverter pe the house is running and the inverter blows. After 4 hours, the inverter runs out. So at 6 in the morning, 7 in the morning, you're pouring sweat. This is July. So this is like the hottest, humidest month you can come back to. And you're pouring sweat onto your pillow and you open your eye and you ask your wife, are you awake? She's like, yes. Like, galti kari aake? You're like, shayad. And this went on for a long time. It was tough to readjust to things here. And of course, you're in a set job there. You have something to do every day. He was starting practice here. It was rough, but now absolutely fine. I got some great advice from a senior once who said, it's never easy if you come back, but you keep thinking of what I could have done there. She said, if you're going to come back to India, cut all ties and say, this is my final call. And I think when you tell yourself that, it gives you peace. And then, of course, every place has its plus and minuses. Somebody also did tell me, देखो जो यहाँ है वहाँ नहीं है, जो वहाँ है यहाँ नहीं है. Need to pick one and stick with it. You can't get the best of both worlds anywhere.
सर प्रोफेशनली यहाँ ऐसा क्या है जो वहाँ नहीं है? फैमिली आई अंडरस्टैंड, पर्सनली आई अंडरस्टैंड.
I think professionally it's easier to settle in the US. You actually get a great start. Like you finish training, you'll have a great job, very good pay, very good quality of life. That will take you 10, 15 years to build in India. So professionally, I think it's better there. Plus the flexibility to move. There are 300 good hospitals in the US you can choose. You could work East Coast. You like the weather on the West Coast. You can look for a job and move to the West Coast. Very easy. You enter a new practice. You doesn't matter. Your work starts next day. In India, you build a practice. It takes you 10 years to build it. You can't just give it up and move cities. You'll start from zero. So I think that professionally, US is a much, much easier place, I think, to settle in and to get going fast. It's on the personal front where India is India, So, it's home. Exactly. It is home. So that is what you get here.
Okay. So, sir, as a head and neck oncosurgeon, what exactly do you do? What is your job profile, the spectrum of diseases, the surgeries you treat? And also, has it changed over the years?
That's a good question. So my basic training is ENT. From there, I went into head neck. So in head neck in India, one of the dominant diseases you'll deal with is mouth cancer. Upper aerodigestive cancer in general, mouth, throat, larynx, pharynx, but by far the commonest is mouth cancer. That's close to 50% of what we treat in a year. The other aspect that's come into head and neck's lap is thyroid. So thyroid cancer is one of the cancers whose incidence is truly increasing. And with a lot of imaging now freely available, like ultrasounds, thyroid cancer is indolent. It lies around in your neck for years before somebody picks it. With so much incidental imaging and availability of ultrasounds at every corner, a lot of thyroid nodules and thyroid cancer is being picked up. And the numbers have exploded. So that probably comprises the second biggest volume of what we deal with. And that number is going to grow. So today, if you're a head and neck surgeon, thyroid will be a very important part of your practice spectrum. That's changed. It wasn't that much part of our practice spectrum. I think I have some thoughts on this. It was very much the general surgeon's domain, thyroid disease. But a lot of, like the general surgeon in our time were head to toe, they would deal with anything. Patients would get
Even
admitted.
orthopedics.
Orthopedics, urology in older times was all under general surgery. But even I remember the SRs in general surgery, they were like tremendously dynamic. Anything in the ER can't figure out where it needs to go, general surgery will admit. Even shock, they're like, we'll treat patients with shock. They did every single thing. A lot of general surgery, I feel now has become lap oriented.
Yes.
So a general surgeon today is not synonymous with, but a lot of them are predominantly lap surgeon. What's been great for us is their interest in thyroid has come down.
Nice.
So that's so we're ready to accept thyroid disease as part of our disease spectrum that we treat. So I think it's a bit of general surgery, maybe moving a little bit away from thyroid and focusing a lot intra-abdominal lap. And right time, right place.
Also, sir, I feel that as a general surgeon or as an orthopedician or any doctor, we understand now that oncosurgery or oncology itself is an interdepartmental thing and multiple departments are involved. Like you cannot just jump into surgery for any other cancer, right?
Right.
If I'm wrong, just correct me.
No, absolutely correct. Oncology is multidisciplinary. In fact, sometimes we say, don't call yourself a head and neck surgeon. Call yourself a head and neck oncologist. You need to think from a global perspective of what's best for this patient, not just think as a surgeon.
Right.
And I think an oncology decision making in the clinic requires the greatest skill. An operation is a technical skill. It's like driving.
Absolutely.
It can be acquired. You do it again and again, you get better. It's a technical skill. But the real science and the real depth in the field is decision making. And that's multidisciplinary. You need to get in all the factors. Every patient brings to you dozens of variables. In a 15-minute consult, you're hearing the history, you're examining the patient, you're looking at the scans. There are about 50 variables you're quickly assessing. and the patient's backdrop, their psychology, their background, their expectations from life. And you're adding them all up to think what's right for this patient. I think that's the biggest skill and takes the longest time to acquire. And you have to think globally. You cannot think just as a surgeon, because you're not just treating a cancer. You're teaching a patient. Sometimes you're treating the whole family as a unit, So you're absolutely right. It's interdisciplinary, and you need to be familiar with what your colleagues do. You need to know what else is available to them and how best to join things up to get the right treatment.
So is there a specialty or a subspecialty which you specifically like in the cancers you deal with?
In head and neck,
Yeah.
I enjoy treating thyroid and parathyroid diseases a lot. I enjoy all aspects of head and neck. There is nothing that I don't. It's already a narrow area.
Yeah, right.
It already is quite narrow. But I think last decade, thyroid and parathyroid has grabbed my passion. Particularly parathyroid disease. I find it fascinating.
Sir, how much percentage of your work is purely surgical? Like, what I mean to say is how much percentage of patients undergo surgery when they see you, or how much are actually treatable medically?
So, see, where I practice is Medanta. It's primarily a referral center. Very much every patient I see is already diagnosed or has been told you probably have a cancer. So I'm not seeing a community-based practice where people with all sorts of lesions are often coming in, and a fraction are cancers and a fraction need your surgical care. For me, a referral will be somebody who's diagnosed as mouth cancer, knows a doctor who's asked them to see me. So they already know their surgical candidates. So almost every patient I see, a new patient, is a potential therapy patient. Let's put it this way. Whether the therapy is surgical or needs radiation or needs a combination of radiation onco. But everybody is with therapeutic intent that I see. It's almost no screening or no pure diagnostics. There'll be a few patients who see you because they have cancer phobia, and there'll be a few patients who'll see you with pre-malignant lesions. But that's maybe 10-15% of what I see. Almost everybody I see has a cancer that needs a therapeutic decision.
So talking about cancer phobias, what exactly do you screen them for? How do you screen them for, and what do you tell them?
We do get patients who are convinced they have cancer. Often they have a little bit of tobacco intake. They're very difficult patients. Very. You see, if you think about it, to tell nothing is wrong with you is a big challenge. मैं आपको बोलूं मेरे घर में दीमक है या नहीं है बताओ. To say आपके घर में दीमक नहीं है is a very difficult thing to be sure of. You can do the best search of your house, but 4 दीमक कहीं हो सकता है होए ना. It's easy if there is a problem and you need to fix it. It's very difficult to say there is no problem with you. So they need meticulous exams. In their head, if they're convinced something is wrong with them, your best advice will often be, they'll be very skeptical of it. Sometimes it takes a couple of visits, and what I also think is you call them back in a couple of months. So you're like, I don't think anything's wrong, but I'll double check just to be sure. And it takes a couple of visits before they gradually feel that nothing is wrong with them. But people come in absolutely convinced they have cancer. Absolutely. Very, very difficult to. And also as a doctor, you also feel, you're at Medanta. You're their final port of call. What if you got it wrong?
What if you miss it?
What if you miss it? It's not like they're going to consult somebody else after you. They've probably consulted 4 people. Now you're the 5th and the last one. What if you miss it? So you do a thorough exam, but I also like to call them back, reassure myself in 2 months, I re-examine them. I also tell myself, nothing is wrong here. Because they do have some vague symptoms. And you don't want to run every scan on them when you clinically don't think it's warranted. But it's a tough question to tell somebody that nothing is wrong with you. That requires the most meticulous checkup.
And sir, what signs are there when the patient should actually see you, and that way he could present you at a treatable stage of cancer?
So if most of the signs are extremely logical. So mouth cancer is what we're talking about, right? The commonest cancer that we see, tobacco related. It starts as an ulcer or a growth in the mouth. So if you have a new growth or a new ulceration, if you have a tooth that gets loose from the growth, you have unexplained pain in the mouth, you have difficulty in swallowing, you have change in your speech, anything that a growth and an ulcer would do if it grows in your mouth are what the symptoms are. Sometimes it spreads to the neck in the lymph nodes, and you get lymph nodes enlarged, guiltia. So a guilty in the neck is also a sign. Now, if you heard this, you're thinking, जब गला खराब होता है तो भी तो गले में दर्द होता है. Should every person with a sore throat go see a head neck surgeon? No, absolutely not. I think persistent symptoms beyond 3 weeks is the reason to go see somebody. So I have pain in the mouth on one side. It hasn't gone for 3 weeks because most common ailments should self-treat within a week, 10 days. A mouth ulcer, a blister, who hasn't had them? You bit your tongue accidentally, etc., etc. They should all self-heal within 7-10 days. If in 3 weeks one of these symptoms are persistent, you should see a ENT or a dental or a head neck, somebody who can examine and decide whether it's an issue of concern or not. And luckily for us, unlike abdomen or thorax, you don't need scans to look inside. You need a light and you just open the mouth and you'll see it. If there's something there, it's there. If it's not there, it's not there. It's very easy to screen and diagnose oral cancer. Not difficult at all. You don't need a fancy test for it.
Clinical screening is enough most of the times.
That's all you need. You look in and you have a lesion that looks suspicious, you biopsy it. But you don't need to run scans to find mouth cancer. It's either there, it starts in the lining, so it's on the surface. So it's either there or it's not there.
Now, sir, coming back to our own track of questions, our original track of questions. Sir, what is the pathway to become a head and neck oncosurgeon after MBBS? Let's start from there.
So, couple of pathways. I trained in ENT, but you could start with training in general surgery.
Okay.
So your basic training would need to be ENT or general surgery, I would think, one of the two. And then you need to super specialize. So today in India, there are many opportunities and many avenues. There's a 3-year MCH program, head and neck recognized. There is now, the national board has a fellowship, FNB in head and neck. That's a 2-year centrally government recognized fellowship.
Okay.
And our national body, FHNO, also runs an excellent training program. It's 2 years structured. It's a common application to the organization, a common pool of applicants, and a common list of accredited institutes. And a fixed structured program is an entrance exam. You get your rank, you pick your institute, you train there for 2 years. So there are, I think, plenty avenues now to train. 20 years ago, there was none. There was no recognized head and neck training program. That's why I had to go abroad. There was no recognized head and neck training program. You could become a head and neck surgeon. There were so many from virtue of work or virtue of experience, but not by virtue of formal structured training in India. That didn't exist 20 years ago.
So now probably you don't absolutely need to go to US for the fellowships.
I don't think so. I mean, if you need to get trained in head neck, India is good. There are excellent institutes offer great training. There is a difference though. The spectrum of disease that they treat in the West is a little different than what we treat here. So we are dominated. So you go to a government hospital, which is where MCH programs will be run. By far, their most dominant volume will be mouth cancer, overwhelmingly so. It could be 70-80% of their volume. You go to the West, mouth cancer may be 25% of what they treat. There'll be many other sites, many other subsites, many other pathologies like skull base and etc. that your spectrum of exposure is different. So it's a different spectrum of exposure. But if you have to treat what's most common in India, you can get pretty good training here.
That's actually different from what I thought, because growing up as a medical student in India, you would think you would see the majority of diseases and a bigger spectrum always as compared to the West, because we have the numbers like the.
I get what you're saying. But see, head and neck programs tend to drive a certain kind of patients into them. And I guess, as I said, mouth cancer is just going to be the biggest dominant number in the high volume government centers. You may not see doing skull base well, need somebody who's niche specialized in it. When your volume is 80% oral cancer, everybody tends to just specialize in that area. Thyroid is growing in all training programs, in all centers. But I think the spectrum is wider in the West. You're right, they don't have the same numbers we have. But they have enough time, enough faculty to super specialize into small areas and develop them. So they get those numbers.
And sir, what advice would you give to a young postgraduate guy or a young graduate who wants to be a ENT surgeon or a head and neck surgeon at that level?
Different for ENT, different for head and neck.
Okay, sir.
I think ENT is a fabulous field.
Right.
It's expanding, like we say, from dura to plura. Everything is coming under ENT. Okay. When I was training, nasal endoscopy was just evolving. Today, nasal endoscopy is a massive field in itself. Just think of the number of people with inflammatory sinus pathology, sinusitis. It's ubiquitous. And nasal endoscopic procedures have gone into dealing with the orbit, dealing with the skull base, dealing with benign tumors, dealing even with cancers now. So it's really exploded. Ear was always a very high volume in ENT. A lot of ear disease in India. Ear infections in the childhood, sometimes ignored, are very common in lower socioeconomic strata, but all over. Ear perforations persistent into adulthood. So ear diseases were always very common in India. But the endoscopy has totally opened up that. Then larynx has opened. Phonosurgery or voice surgery has become a very niche area. I think ENT is a great field. And then you can pick. So not only is there a wide spectrum and a wide volume of patients to treat, but if you want to go into a niche and you're passionate on one area, you want to develop a strong reputation, you can pick any one of the facets. You could look at nose, ear, voice, pediatric ENT. You could branch into facial plastics, although that's not that common, but it is an option. Or you could pick head and neck if you're insane.
Sir, if somebody wants to pick head and neck after ENT, what would you say are like the pros or the cons? Like what motivation can you give to them?
I think you have to be very passionate about it because the field will test your resilience. It's very labor intensive. Very. Some of the longest hours in the hospital are spent by a head and neck surgeon. And it is very... it's a weird feeling when you're the last car pulling out of the parking lot every evening. You know, it's a funny feeling.
Right.
You're like, सब चले गए, हॉस्पिटल में उल्लू बोल रहे हैं, एक मैं ही हूँ जो घर जा रहा है इस समय. So you have to reconcile that you'll have very, very long hours in the hospital. That's just part and parcel. So you have to be very passionate and love what you do. If you don't, I think you will struggle as a head and neck surgeon. You will. But the field is exciting. I didn't know what life as a head and neck surgeon was going to be. We worked in AIIMS, sure, busy department, but work starts at 8:30, work finishes at 5:36, you're done. The evening is yours and you're a trainee. So if you're on call, you're on call, otherwise it's evening's free. You go do what you do, I didn't know what real life as a head and neck surgeon was when I took the field. I took it purely because of passion. And, but the field's great. But you can only do it if you're incredibly passionate. In fact, most people who want to join head and neck, what I tell them is, I do tell them don't give up your basic ENT training. Like if there is an opportunity to do SR-ship in ENT or do a head and neck training, I'll say do the SR-ship in ENT. Get wide and good and do head and neck after that. So even if you're passionate about it, let head and neck be your passion. It's challenging to make head and neck as a bread and butter profession. It's not easy. It is challenging. It takes a long time to build a practice in head and neck. And there's no guarantee you'll always build it to a good volume. So you need to have a bread and butter. So your stress of work or earning is not there. I think ENT offers that. Because ENT, the rise is quick even when you're young. And if head and neck's your passion, sure, keep that as 20% of your practice and it can evolve to 50% over time. But you need a bread and butter work, something that you go to work and there's work for you every day. So I tell young people that if you want to choose head and neck as a pure head and neck surgeon, nothing else, that's a bigger struggle. Be prepared for it. Otherwise, get your ENT training good. Do head and neck on top of that. Have a good mix of both. You'll also find employment very easy. See, any new hospital that's 200 beds, 150 beds needs an ENT surgeon. It's one of the first few fields people get employment in. You'll have general physicians coming in, internal medicine, you'll have cardiology, you'll have orthopedic, you'll have neurosurgeon, you'll have ENT. It's one of the first 10, 12 fields they'll take in. And of 500 patients who may walk into the hospital, 5 or 10 will have an ENT problem. They'll have Gala kharab, khansi, zukam, ear pain, sinus issues, allergies, etc., etc. Your practice takes off very fast. In a fresh hospital, ENT is one of the fastest rising practices. It goes up very quick. That's the medical part of ENT, the OPD practice. There are lots of also OPD procedures in ENT today. Endoscopies, laryngoscopy. So you'll start OPD office procedures very early. The surgical practice will take time. That's sort of reputation based a bit. So that takes a longer time. But you get going very quickly. So ENT, I think, is a great field, and head neck, as I say, one's bread and the other is the butter or top.
So you have talked about how exciting it is, but you have only said that it is a long working hour. It takes time. You need to specialize and so many other things. But now I really want to know, what is the exciting part of head and neck surgery? Is it financially rewarding or just or
No, financially, it's, I think, for hours spent to remuneration, it's probably among the worst surgical fields. No, it is. It is.
okay?
I mean, you work 10 hours on a long case. That's one case done in a day. An orthopedician will replace 5 pairs of joints in that much time. An eye surgeon can do 10 cataracts in a working day and still be home at 5 in the evening with a glass of wine.
Absolutely, huh?
So, as a surgical field, remuneration for hours spent is the lowest probably. I don't know if there is any field lower than this.
Okay.
But it's passionate because the anatomy that I found the least fascinating as undergrad, which is head and neck and all the cranial nerves and all, now that's your life. You know, once you get familiar with that, it's dealing with all that. It becomes, I don't know what the right simile is, but if you like driving a rally car, then that rally car driving is your thrill. Then driving on a plain road is not good enough for you. So things that I little bit moved away and you have to just read them up to pass an exam are now my life. And you feel so comfortable with dealing with nerves and vessels and getting tumors out. And then there's no, for a surgeon, as a pure technician, if you're thinking, the thrill of doing a case well is just incredible. Plus, every patient's different. So I don't want to sound demeaning to any field. I don't mean it at all. And my understanding may be limited. But for example, a joint replacement is a very standardized cut and paste operation. Yeah. I don't know if I've correctly put it or not. A gallbladder resection, if it's simple and not a complicated case, is a same step, same way, same time, every single time. Every head and neck disease is unique. So the cancer could be on the cheek, on the jaw, on the tongue, in one area, on 2 areas, big, medium, small, large. It's titrated resection. See, we don't do whole organ resections. I have a stomach cancer, 2 centimeters, 4 centimeters, 5 centimeters, 3 centimeters. Gastrectomy. The whole stomach comes out. Chop, chop, out. Same with colon cancer. Chop, chop, out, join. Every resection in head and neck is titrated. There's nothing known as chop, chop and the whole organ out. You don't take the whole tongue out for a small tongue cancer. You don't take the whole mandible out for a small jaw cancer. Every resection is titrated. So every resection tests your skill. So every day you walk in, it's a new challenge and a new skill, and not a new skill, but a new challenge to create. So it keeps you excited. Like I guess one could get a bit bored doing the same thing day in, day out for 40 years. If it's just the same thing doing again and again, it could get tiresome a little bit in some ways. Doesn't happen in head and neck because every cancer is different. Every single one you deal with is different. There is no standard operation, one size fits all for every disease. So I think that's
a great answer, sir. Yes. So if I can ask this question also, MBBS graduate to decide a surgical field versus a medical field is also a very difficult question, I would say. And it's actually life-changing. Sir, what do you think makes a good surgeon? Is it the mindset? Is it the training? Or what do you need to know about yourself to choose surgery?
I'm not sure if I can objectivize a list for you. I think it's an inner calling. Like even in MBBS, I look back at my colleagues and friends. In second, third year, some were very clear they're going to be physicians. I was very clear I was going to be a surgeon. In fact, I wanted to do general surgery. But as it happened, I picked ENT. I think it's an inner calling. That surgical and medical division is so deep, I think. It's a different mindset and you kind of have to know your mindset. You do have to know your mindset. I think within a surgical field, picking a practice or a specialty, or within a medical field, picking a specialty is a little more nuanced. But I think between the two, it's an inner calling. You just have this gut feeling. This is what I was built to do.
And sir, you've talked about the financial rewards in head and neck. What about the financial rewards in ENT?
Oh, much better.
Much better.
Yeah, ENT luckily is... So ENT, if you think of... MBBS में एक स्टूडेंट ने कभी मुझे कहा था, मेरे से जूनियर है, यार एक बड़े सर्जन होते हैं, न्यूरो सर्जन्स, कार्डियक सर्जन्स, एक छोटे सर्जन होते हैं, आई सर्जन्स, एक ना बीच के होते हैं जैसे ENT. That's how the world, that was his MBBS crude view of surgical fields, you know. So ENT was always a very mediocre. There was not much glamour with being an ENT surgeon. I think so. Matlab, in our field, there is glamour for good surgeons. But to the outside world, you say you're a cardiac surgeon, it's a little different. You say you're an ENT surgeon, it's like, theek hai. You know how it is, you know. That's how it was at least 30 years ago. ENT is now being recognized as a sort of subspecialty in itself. So, and the remuneration is moving parallel. So the moment, why does one operation get billed at a higher rate than the other? It's not like the hands move more. It's just how, like, what's the worth of an operation? So difficult to answer it. You know, how do you give a monetary value to a surgery? It's so difficult to do that. It's just how it's viewed by doctors, society, people. Okay, that's the worth ascribed to an operation. So ENT, I think today is being recognized that it's just not another mediocre field. It requires specialization, special skill sets, and once you get that recognition, the remuneration is better. So ENT remuneration, I think, is very decent for the number of hours you put in. It's pretty much appropriate for that.
Okay, and sir, the training itself after ENT or as a head and neck oncosurgeon, you have already mentioned that India is now self-sufficient. It can create good head and neck oncosurgeons. But do you still feel there is some lacuna that needs to be filled in the training?
I think so. I may displease some people with their answers.
Okay.
With my answer. But I think I don't want to convey a wrong message, which I might, because my choice of words may not be appropriate. But I think in life in India, adjust kar lo and chalta hai is part of our culture.
Right.
Thankfully, to a large degree, medicine has managed to maintain its self-standard by self-regulation and a lot of self-pride in people that we want to be very good. Rather than external forces demanding you be very good, it's just self-driven. And I think people who choose medicine are often self-driven to become very good at what they do. But you're not completely outside the influence of how life goes around you. As I said, you culturally just absorb into a place and you take that place. So I think sometimes what our training can lack is that it could have been done better and it just doesn't get there sometimes. So excellent quality sometimes to 90%, but the climb to 95 or 97 is sometimes not there. If I had to, I think that's what I would think is what we need to tell our trainees to focus on, that each patient is just critical. It's not, I treated 100 patients this year and majority did well. Every patient you need to just try and do the best you can. Sometimes, I don't know if that comes through, especially if in a very high volume place. It's very easy to just look at the volumes and think, yes, we are doing well, but not look at individuals sometimes and realize, did you do very well with every individual? I think that's one aspect of a fellowship we could imbibe that culture.
Sir, we have talked about unfavorable outcomes. So when this happens, and probably happens a lot more frequently in your field than ours, sir, do the patients or the relatives blame you in the end?
You get the sense sometimes they do. And sometimes I think it stems from, if things haven't gone well, to kuch galti to hoegi. That's, I think, is how the family's point of view is. So if you're looking to blame, you're the target in front, right? It's harsh. And I think a lot depends also on the relationship you've developed with the patient and the family. Sometimes you can see they have innate trust in you. And even if things don't go well, they'll understand you did well, and just it's fate sometimes. Because we forget medicine is such a human science. So it has all the frailties that come with being a human being. If a patient passes through my service, let's say gets admitted, has an operated, stays for a week and goes home, there are 25 decisions you're making every day on the fly on that patient. 25 every day. And decisions in medicine are all about probability. This is what I think is the right to do. There's never always a black and white. Luckily, with your training and experience, you get things right most of the time. Sometimes you don't. I think that uncertainty that there could have been a human frailty is less acceptable in society today. 30-40 years ago, they were like, हम डॉक्टर के पास ले गए, उन्हें कोशिश करी, नहीं ठीक हुए. Was a very acceptable outcome. It just seems less acceptable in society today. Maybe I think we propagate medicine, we showcase technology a lot in medicine, and we make it seem like there's technology, things can't go wrong, everything will be perfect. And I think that's a very wrong impression to give. At its core, it's human, and it'll have mistakes, or it'll have not mistakes, but errors of judgment, or playing the odds. In medicine, I always tell people, you're always playing the odds. You're seeing what you think will be best, and you go that way. Sometimes the odds fall in your favor, sometimes they don't.
Right.
But yeah, you do get blamed, and I feel it's a bit harsh. It drains you. That I think
It affects you as well.
Oh, big. I think the most taxing thing in medicine is not the hours. So people, when they hear of my field, oh, you do 12-hour operations, that's so tough. It's not. I'm happy to take the glamour, but it's really not. You think of a truck driver, he drives 20 hours. He doesn't think that's very difficult. To me, you said, will you drive for 20 hours? Like, I can't. It's a natural acquired skill. It comes to you. It just comes to you. It doesn't feel like heavy labor if you're 10 hours in a surgery. It just doesn't. It's the mental draining that gets you. It's the constant stress of assessment, outcomes, things sometimes going well, not going well, the stress of dealing with the medical issue, the stress of dealing with the family, the stress of sometimes looking at how much cost the patient will bear with your interventions. That drains you. That I think is the roughest part of medicine practice in India, is the emotional aging that you get.
Right. And the cost, and in spite of that, the outcome may not be favorable.
Correct. Particularly in oncology. Biology is king. Biology is a famous saying by Blake Cady. Biology is king, which means your disease nature will decide your outcome. Selection is queen, means how you make your decisions, what you choose to do is next best. Technical expertise is jack, least important.
Right.
But we sometimes think jack will beat queen and king. They often don't. So sometimes the nature of the disease will decide the outcome. Doesn't matter how good the treatment was. That uncertainty hangs over a patient like a sword for a few years. Why is cancer feared? It's just another disease. I mean, heart disease should be feared, but people walk around with heart blockage saying, bypass kara lenge, stent kara lenge. When that can take you in an instant. You may go to sleep and wake up next morning. You may not. It can take you in an instant. But people are more easy dealing with that than the uncertainty of treating cancer. Because for 3 years or 5 years, you have this sword over your head. And I think that's why the word is feared. Not the treatment, not only the side effects. I think it's the uncertainty which eats away at people. And that's why cancer is so difficult to deal with.
And sir, how do you break this news to a patient or their family? And sometimes when the family members tell you that please don't talk to, or please don't tell the diagnosis to my mother-in-law or something like that.
I've changed over the years, and I'll take an anecdote. So when I trained in the US, it's a very different system. Patient is center of all. Patient is king. Patient needs to know everything in black and white. Patient needs to tell you what you want to do. People think practicing in the US is tough because it's litigious and all. I thought practicing in US is less emotionally draining.
Okay.
Because you lay everything in front of the patient. This is what you have. This is what I can do. This is what can go right. This is what can go wrong. This is your alternative. You tell me what you would like me to do. Patient takes the call.
Okay.
Right? You make sure they understand everything, but patient makes the call. He's the center of everything. It's different in India. Often you have to make the call for the patient. So you get the benefit when you make it right, but you also get the blame when you make the call wrong or things don't go well. So so it's a little different here than in the US, this part. I found practice in the US actually easier, less emotionally draining. Less emotionally draining. And there's something else that I felt, which is also interesting, that medicine is often thought of as transactional in the US, right? Like we feel it's more impersonal, right? That's what we all say here. Okay, the patient comes to you, they're paying your consultation, your fees, you're doing a treatment for them, you're explaining risk benefits. It's transactional. But when patients in the US saw that you are going above and beyond your call of duty, there is true gratitude. Really, I found that so much more in a society that we think views doctors as transactional, that the gratitude is there because they can see when you're putting in the effort. Like, this is beyond what is expected of you. There was never a day in clinic, there wasn't a basket of sweets given by some patient who had come. Never. Years after their treatment, you can feel, when I left the US, my kids were small. I had a patient who was admitted in my service many times. And I took care of her, and I got talking to her sisters, and I just got to know them. She had 3-4 admissions while I was there. Very rough treatment, multiple cancers, multiple surgeries, etc., etc., etc. And we got talking. I told her about kids, we are going home. Before I left, her 2 sisters stitched handmade blankets. Wow. Stitched. Think US labor handmade. Kitna precious hai wahan pe. And gave them to me, saying, these are for your kids. And I was just a fellow. I wasn't even their treating consultant. But they could see the effort you've put in, the care that you have. And that really touched me. We got those 2 blankets. My kids used them while growing up. Another patient I had, one of the first patients on my clinic service there, when I was working, there was talk of, I'm going to go back to India. And so I'm going to make some savings in the US. I'm going to go back. Hopefully I'll save enough to one day buy a house, etc., etc. Before I left, he gave me a little plaque. And when you entered my house, you would have seen it outside. He gave me this plaque. He's like, when you move into your house, hang it outside. So, very touching sometimes. So sometimes, you'll have patients who can see that you're going above and beyond your expected duty or expected professionalism and appreciate you for that. And that feels really, really nice.
I think especially for a surgeon, because the patient is handing over their lives to you, and also as in, right?
I think the bond is stronger because when you enter an operation, you pretty much hand over your body to the surgeon and the team. There's anesthesia, there's a lot of people, but your face-to-face contact has been with your surgeon, right? You hand yourself over on the hope that they'll put me to sleep, they'll tinker around in my body, and they'll wake me up. Like, I will wake up, my eyes will open. This is not the last time I'm closing my eyes. It's to completely leave all control you have over yourself and your body in life and hand it over to somebody else. And that takes a lot of faith and a lot of trust. I've had anesthesia once, and as I shut my eyes, and I was like, I just hope they open at the end of the operation. And of course they did. And the gratitude I felt for the anesthesia team is like, then you realize how much it is to just completely surrender yourself and say, in 5 seconds, I will have no control on what happens to me for the next 2 hours. I'm just completely trusting that they'll do the best they can and things will work out well. So that bond sometimes I think can get very strong. Different than when you're being treated for a medical issue. You almost always never lose control. You can control the medicines you want. You may stop the treatment. You may decide, I want to change my doctor midway through. You have none of that control when in the middle of an operation. It's a trust that we also need to appreciate. That is.
And a big shout out to anesthetists, sir. The surgeons take all the glory and also the blame.
Yeah.
But anesthetist, a good anesthetist will change everything in your operation.
You need to go under anesthesia once to know how much you put in their hands.
Right.
Yeah. Absolutely.
Sir, coming back to the original question, what tips do you have how to break bad news to the patient, especially cancer?
So in the US, I was trained patient is centric of everything. Tell him as it is. In fact, you're legally bound to tell exactly the way it is. I bought into that concept. Okay. And when I came back to India, I would counsel patients very frankly. Like, this is what you have. This is what needs to be done. These are the effects you'll have. That was my training. As I said, that was the culture imbibed into me. One anecdote did change me a little bit.
Okay.
I had a youngish lady, 30 odd, with young kids. She had a bad tumor, had been operated about 3 times in various centers, and had a recurrence, and had now come to me for an opinion what to do, accompanied by her family, I think a brother, if I remember. And in my opinion, there was no salvage possible for her. Like, there was no point. She had been told, get another operation done. And I felt is of no value. It's not going to help her. And I counseled her. Like I said, I don't think an operation is going to help you. And I felt, A, the patient needs to know the truth. And B, my belief is that, but when you say there's no operation available, you also kind of know that you're implying you may not have much life left. You know, that's what you're implying, unsaid, but you're implying that. And I thought, whatever time she has, she should spend with her kids at home, not getting operations after operations in hospitals. And if there's 6 months of life, don't spend 4 months in a hospital. Spend that whatever time you have with your family. So that was the innate belief that I would counsel somebody, that if you have limited time left, you should know, and you should use that time, whatever jo ichha hai life mein karne ka kar lo. But somebody has to tell you you have limited time. I thought I did right by the patient. Her family came back to me a couple of days later saying, हमने उनका operation करा लिया. I was like, अच्छा. They're like, डॉक्टर साहब, वैसे तो उनको जाना ही था 6 महीने में, आपने तो उनको उसी दिन मार दिया.
Oh.
That really hurt. So I tempered my approach a little bit. And now I temper it based on the patient's, what I judge as the patient's strength to bear the news. Some people are okay to counsel, but they don't want to hear the word cancer because of the fear. They're like, don't use the C word. And then I won't. I'll respect them. You have to work around it. It's Indian culture. Like, it's sometimes culturally, we may not be very strong in taking bad news. Like, I can't see many people saying, doctor told me I've got 3 months to live. Okay, I'm going to go live it up, whatever I want to do. That's not our culture, you know. It's just sometimes people are just not strong enough to take that. But I also think that nobody should enter treatment without a good understanding of what they're getting done and why they're getting it done. Like, you can't take a patient in for a head and neck surgery not telling them what you're doing or why you're doing, because their life will change from your treatment. They have full right to know what will happen and why they're getting it done. So you always counsel the family. That's how I approach it. I always make sure the family knows, and I tell the family, go home, break it in the best words you think to the patient. Make sure they know what the kind of, you know the patient better than I do, how to phrase it, how to say it. I may say it in a harsher way. But bring the patient back to me. Make sure they speak to me and they ask me any questions they have. Because I think a patient prepared for an operation is going to do much better in recovery, be a lot more cooperative than somebody who's completely unprepared for what's going to happen to them. They can take a shock very badly. And sometimes the fears are unfounded in medicine. Like, they build the fear up of what's going to happen to them many-fold more than what actually will happen. So they should express their fears to you. Tell them, this is what I'm scared of. This is what will happen to me. And then you can reassure them, like, it's not how you think it is.
And it's such a visible thing, the head and neck cancers. That's also a big part of your treatment.
It is. When you treat mouth cancer, the patient carries your signature on their face for the rest of your life. It's just there in everything they say, they speak, how they look. But I will also tell you that humans are a lot more resilient than we think we are. I will get Matajis in the OPD, like you said, कि family से Mataji को मत बोलना क्या है, वो तो ऐसी ढह जाएंगी. And then over 2-3 visits, you build trust and you gradually tell it. And sometimes that so-called failed Mataji will be the strongest member in the family. They'll be like, beta operation karna hai karo, jo karna hai karo, main tayar hu. And this is the family who thought that you couldn't even tell them that operation hona hai ya cancer hai. Perspective at 70 of life can be very different than what we have at 50 or somebody has at 30. Somebody who's lived their life has a very clear expectation of what they want more. And they can be incredibly strong people. So people can be much more resilient. And I've seen this again and again. People whom you thought are not going to be able to deal with this in their life turn out to have inner strength that even they didn't know they have. And they just do great sometimes.
So tell me about some complex case you did which stuck with you for forever, I would say, or which affected you.
So I think the ones that you remember the most are your failures.
Okay.
Right? So I'll share with you one that impacted me and still does. Like, I'll never forget that case. So this was a youngish professional, could have been 40 something, had been treated for a cancer outside, had recurrent disease, but it was a slow growing cancer. It was one of those that grows slowly over months and years, but clearly had recurrent disease, was starting to get problems. Couldn't eat, had a feeding tube placed. So was living on a feeding tube, but a professional. And I saw him, and he had a very difficult cancer to try to reoperate. I kind of was reluctant. And but there was really nothing else we could offer him. It was one of those cancers where chemo didn't work. There was nothing else you could offer him. But he could have pulled with that cancer for a year, maybe 2 years, but with a feeding tube, like with a very poor quality of life, with an altered voice, with a life that he couldn't go out anywhere. And obviously with more problems down the road. So over a few visits, over a few weeks, he kept telling me, Doctor Sahab, आप ऑपरेशन करिए मेरा. I was like, मुझे नहीं लगता इस कैंसर को हम पूरा निकाल पाएंगे, like फायदा नहीं है. But eventually I bought into his wish that you operate. It took me a few months and it was a big operation. That was probably the longest operation I did. We started at 8 in the morning. I finished at 6 in the morning next day.
Oh, wow.
It was 22 hours. Us, plastic surgery, and his carotid artery had to be resected. So vascular surgery, like it was a big operation. And we managed to get the cancer out in a reasonably satisfactory manner. Like we would have bought him something from that operation, if not a completely cancer-free existence, but at least a couple of years more. But next morning, he didn't wake up from surgery. He had stroked out in the brain with multiple infarcts. He just never woke up. And I had the most unpleasant duty of, after 24 hours of watching if anything's getting better, even another day when things were not better, an intensivist told her, look, he's not coming out. I had to sit down with his wife in the ICU and tell her, look, he's not going to make it. And she was, of course, distraught because she wanted him to carry on with his life the way it was. You know, like, oh, hai, jaise bhi hai. He did not want to live this life. He was like, I don't want to live with this feeding tube for another year, 2 years. His wife, of course, wanted him around. So you could see the regret in her eyes of, we should not have got this surgery done. And that curse hit me, like when I talked to her. They never blamed me. I never felt that for a second. They just felt great disappointment. And I talked to a senior colleague of mine and I said, I don't know why, but this case affects me so much. And he said, probably you identify with the patient very well. This was a youngish person, professional. So you kind of feel that's you. That's you, that's your family. Like you can feel the identification with the patient. So that's why that impacts you more. And until this date, I just, how do I reconcile? I say, look, I think what the patient wanted is what I did. Like I respected his wishes. He's like, give me a shot with surgery. That's what you tell yourself. You got to give yourself some solace that at least I did right by the patient. That's how you deal with failures. You just got to know you did right by the patient.
So do you think it affects you a lot mentally? Does your family says that you should not bring grief to home or something like that? Has that happened?
My family says I frown too much.
That's a lighter way to put it.
They do. And I think different doctors deal with the stress of work differently. I actually admire people who can get on with things even when things are not good. I find it little more challenging to reconcile with failures. I do. But what you have to keep telling yourself is you did the best you can. You made what you thought were the right decisions at that time. And if you had to do it again, you would make the same decisions again. It's just that, as I said, you play the odds and sometimes the odds don't fall in your favor. You have to tell yourself something to deal with this. Otherwise, you'll just crush. Like you will have a mental disintegration in 10 years in medicine. You have to find a way to reconcile to your failures. You have to. Everybody has their own way. But I do hope with more white hair and more wisdom, I will be a little more pragmatic in life. Things always don't go right. They go wrong. Sometimes trying to be a perfectionist is just bad on you. Everything should go right every single time. Why didn't it go right? Sometimes you have to reconcile. Life is life. Things always don't go well.
And sir, the patients that survive, the incidence of depression is huge in them.
Yeah.
So what do you have to...
Very common, extremely unrecognized. I love to talk about it on scientific forums. And I was sensitized to this by a trainee who had come in from the US. He was with us for a year. And his university had a lot of work in depression in head and neck. And he sensitized me to this, that it's very common. About 30% of patients have it. But as in society, we like to sidestep it as doctors. We kind of find it difficult to bring that up. But I do now. And I ask two questions if I get the slightest sense this patient's not full of life when they walk into your room. That क्या मन मायूस रहता है या आपको जो पहले करते थे उसमें खुशी अब नहीं मिलती जो पहले खुशी मिलती थी. Like I used to like going watch movies. अब मेरा मन नहीं करता है मूवी देखने का. And I think there are many performers you can use, but I find just simple questions are easy. You get the sense the patient's not enjoying their life as they can. And of course you understand a diagnosis of cancer, some anxiety is going to be there. When you feel it's out of proportion and affecting their life or affecting their recovery, I think you need to counsel them to get help. And because you're the doctor, they've developed a strong relationship. I mean, they had an operation under you. They put a lot of faith in you. They have a lot of trust in you. So then you can gently guide them towards seeing a psychiatrist, even though there's so much stigma with somebody seeing a psychiatrist. There's a lot of societal stigma still with it. But I think you can work with them over 1 or 2 visits and make sure they get to see somebody, get some help, so that, if you're lucky and the patient's lucky and you've cured them, these 3 years should not be wasted in depression. Life is so precious for a cancer patient. Sometimes you're cured and you think, I lived 20 years, but I wasted the first 5 years in anxiety and depression. Sometimes you're not cured and you're going to live 3 years and you're like, jo 3 saal the, wo bhi maine theek se nahi jiye. So either way, you need to get them to have every day meaningful for them. So yeah, it needs to be addressed.
And so they also have substance abuse problems, a lot of your patients. For them, do you refer them to the psychiatrist or a de-addiction center?
We do. Generally with a diagnosis of cancer, everything gets quit.
Acha, okay.
Sometimes you ask them, कब से छोड़ी? They're like, बस hospital में enter करते करते छोड़िए. So it's very unlikely that a patient will start treatment while still, let's say, taking tobacco. But relapse is not uncommon. Couple of years go by, the anxiety and the fear is gone. Relapse is not uncommon. You have to be on the watch for it. They'll not open up to you about it. You get a sense from the family, or you look in the mouth and you start seeing some new changes coming, and then you have to just ask them, are you taking tobacco again? And if they go, nahi, doc sahab, you kind of know they are. You have to straight away tell them what it means. And I think our rate of getting people to quit is very high. But you have to address this in clinic.
So how do you do that? How do you make them quit? Like, is it motivation? Is it fear of death? What works?
Fear of death is too harsh, but I think you make them realize how lucky they are. I'm talking of people who've been treated and are in remission but relapsing. That how lucky they are to have survived what's a life-taking disease, and how much pain they had to take to get treated. And are they really willing to gamble everything and go on and take that thing again, that I will go through it. I mean, you make them understand in different words. I mean, you can give many examples. I'll tell them, like, they're like, हमारे दादाजी ने तो 70 तक बीड़ी पिया, उनको तो कुछ नहीं हुआ. And like, they had good cancer defenses. You don't. The best evidence is you developed a cancer. There is no bigger proof that you will lose the battle against cancer-causing chemicals, because your body's shown it once. It can't fight cancer-causing chemicals. It's lost the battle once. You'll lose it again. You're not superpowered or lucky or superhuman. So you have to make them understand it, and generally people do. They come around. Yeah. Few are resilient, but most come around. But yeah, psychiatric help, psychological counseling, medication, nicotine replacement therapy, etc. Everything has a role. You just need to escalate it to the patient's need.
Sir, as it is with heart disease, once you stop smoking, the risk goes down maybe after a few years, not instantly. So does the same happen with malignancy?
So the risk does come down very gradually. It takes decades for the risk to reduce, but it never reduces to baseline. So if you've ever taken tobacco, you are carrying an enhanced risk for mouth cancer or head and neck cancer all your life. But it does come down. I should not convey that quitting is of no benefit. The risk will reduce substantially, but never down to baseline.
And do you have a number of years, like 10 years, 20 years?
20 years for it to reduce to its down. So it's a curve that runs like this and then plateaus above baseline.
And what's the average age of that a patient presents to you with cancer?
Chewed tobacco, which is very prevalent in North India, it's a younger patient than in the Western world who has smoked tobacco-induced cancers. We see patients in 40s, 50s. I mean, we've had patients in their teens also with chewed tobacco-related cancer. But chewed tobacco seems to me to generate cancers earlier, in patients with younger ages than smoked tobacco. Possibly the concentration exposure is much higher.
And sir, these days you also see teenagers smoking a lot. So does starting earlier has a greater risk? Or maybe because of the duration of the years?
I don't think there is data to say starting earlier, but of course, if you say starting in early teens, possibly because your cells are more vulnerable, and that fits into the biology of how cancer happens from genetic alterations. But I don't know if the age of starting is relevant. Certainly the number of pack years smoked is. And yes, very common in teens. It's a social thing, I think. Smoking is still very socially acceptable in India. In fact, one would say in certain circles, it's kind of not the done thing, but maybe it's the done thing at a party, etc., etc. Maybe it's cool to be seen smoking, That might be there still with many sections. But culturally very acceptable. You walk the streets in the US, you will see nobody smoking. None.
Okay.
If you are, it's often in an alley in a corner furtively. It's almost frowned down upon. Like how would you frown upon on a drug addict sitting on a street? The person's got an addiction, right? I think it's looked upon a little similarly. Very, very unacceptable. Europe still very prevalent, still very normal to see people smoking and walking around. Culturally acceptable, still very acceptable in India. But US has looked down upon, and I think that's why the rates have dropped there. But probably on the rise here for us.
And sir, what about alcohol? Does stopping alcohol also brings down the risk of cancer?
You take any carcinogen out, your risk of developing a cancer will come down.
Conceptually it's the same thing.
Conceptually the same.
Okay, got it. And sir, smoking and alcohol together, how bad is that?
एक और एक 11, दो नहीं होते हैं. Synergistic effects. Each independent, two together, much worse.
Right. And sir, which is the bigger evil if you can pick one? Smoking tobacco, chewing tobacco, alcohol, or some other substance?
I would say tobacco is probably the bigger evil.
Okay.
Also because you can't be drinking alcohol 24 hours a day. I mean, you can, but for most part, that's not what people are doing. But you can be taking tobacco pretty much all waking hours of your life.
Right.
So, you can't be drunk at work, but you could go out and smoke at work. So, plus the carcinogenic effect possibly more potent with tobacco than with alcohol. So, in all ways, tobacco is probably of the two the bigger evil. There could be social intake of alcohol and that may or may not indicate a bigger risk. There is no safe limit though. We don't know what's a safe limit. We really don't. But let's say somebody says, I have 2 drinks in a month. You're thinking that's probably okay. It should not impart a thing. But you have very few people who say, I smoke only 2 cigarettes in a month. That's very unusual.
Right.
It's very unusual. There are some, but that's very unusual. So tobacco is probably the worst.
And also with smoking, even if you're smoking 2 a month, it's not.
Correct. That probably is still, to my mind, a higher impact than maybe 2 drinks a month.
Right. And so there is another evil, vaping. What do you have to say about that?
Evolving evil, we're still understanding the effects of vaping. See, understand with tobacco also. Till the 1950s, its association was cancer was not there.
Okay.
I mean, the tobacco industry made
Yeah.
sure that it just doesn't come out into the open. It took so many hundreds of years to prove that it's related to cancer. Hundreds of years. Vaping is a new phenomenon. It's evolving. We'll probably know all the effects over decades.
Okay.
But it's quite prevalent amongst the youth. Very prevalent. Again, in a common group, vaping would be more socially acceptable than, let's say, blowing out smoke.
Absolutely.
But you are taking unnatural, harmful chemical, heavy metals, whatnot gets vaporized and puts into your body. There are associations with lung disease and many other things. Plus, I mean, you have to think, most of medicine is common sense. Our human body was not evolved to take in chemicals it's not used to. And that's what you're basically doing. I mean, you won't put your mouth to an exhaust of a car and inhale it and say, probably nothing will happen to me. You know that's a chemical that's not supposed to be in your blood. Same with vaping. Think of it similarly. But very common. I think it's going to be a challenge going forward.
And sir, we also read it in the news pretty often that spending a day in Delhi is probably equivalent to smoking 20 cigarettes a day.
Not sure if that relates to cancer. I think that may be hyperbole, but it may be similar to saying the damage it will do on your lungs. And that, I think, there is significant causal association that lungs are getting hurt for people who live in polluted cities. Not so much more with cancer, I think.
Okay. And sir, what about the cancers that people get who are not smoker or who have never smoked in their life? What's the main culprit there?
So we talked alcohol. I think the other big epidemic on the horizon is HPV-driven cancers. So HPV is human papillomavirus. It's a sexually transmitted virus. And you can get HPV infections in your throat from unprotected oral sex. It's also related to the number of sexual partners, etc., etc. In the West, it's an epidemic. And your typical patient of HPV-driven throat cancer is a young 30-something, never smoker.
Oh.
It's very young people, never smoked, never took tobacco. And depending on cities where you practice, throat cancer in some cities now, 90% they are seeing is HPV-driven of throat cancers they are treating.
Even more than substance abuse?
90%, like almost all. It's an epidemic. Of course, there's a latency period between acquiring infection, developing a cancer. So US is seeing, or a lot of Western countries are seeing the full-blown epidemic now, or maybe not even the full-blown, but they're seeing the effects of what may be HPV transmission in society a couple of decades earlier. You see how our society is going. You see that happening on the horizon.
But we have a vaccine for that.
Yes, we do. Yes, we do. Fortunately, we do. And effective. Absolutely. And effective. Certainly proven for cervical cancer. But by corollary, if you can eliminate HPV infections, you're going to eliminate HPV-driven throat cancer as well. Yes, we do. So hopefully we may not get the epidemic that we fear.
Right. But it's not recommended as of today, right?
It is.
HPV.
It is.
Okay.
For young girls and before sexual activity.
For the cervical cancer part.
Correct. And the corollary is that if you prevent HPV infections, then you're unlikely to get it transmitted to your throat.
Because the route is the same.
The route is the same. And in the US, recommended for men as well. Of course, it takes years, decades to prove the efficacy. But the logic seems very, very sound. I guess culturally a difficult topic to broach in Indian households.
Absolutely. Right. And so do you see the difference in disease presentation among the cancers because of smoking or non-smoking or HPV? Like, is the prognosis different? Is the presentation different?
So HPV has a much better prognosis than tobacco-driven. In fact, it's so unique that we have now a new staging system for HPV-driven throat cancer. So size for size, lymph node extension, HPV-driven cancer will be staged lesser than a smoking-driven cancer when the volume is exactly the same in the body because the outcomes are much better. Much better, like remarkably so that the staging system had to be revised for HPV-driven cancers. Presentation-wise, I think, as I said, chewed tobacco tends to happen earlier. Chewing tobacco is also very prevalent in the lower socioeconomic strata. So access to healthcare, ignorance, everything plays a part. They often present with much more advanced stage disease. Often.
So you talked about adjusting back in India. How difficult was it?
Let me tell you an anecdote.
Okay.
So my neighbor in undergrad in the hostel is somebody 3 years senior to me. He was a close friend. We had strong bonds, and you kind of identify with their mindset and how they think. He went to the US after his MBBS and did his residency, medical oncology, trained there. He came back to India in 2002. And when he came back, he said, Deepak, I'm back. Let's start meeting for lunches. So every month, 3 of us who were wingmates would meet for a lunch. And we would chat. And मैंने उससे पूछा, तुम वापस क्यों आए? मतलब you were 6-7 years in the US, trained, medical oncology, hem-onc, everything. वापस क्यों आए? He's like, Deepak, US में ना पैसा है, पैसा है, पैसा है, बहुत पैसा है, और कुछ नहीं है. I was like, ठीक है. Next year I was heading out for my fellowship. I joined my fellowship. This line is repeating in my head because my close friend said it. I kind of respect his thoughts. 2 साल काम किया, वहाँ जॉब ऑफर्स आए. Yeah, I was like, no नौकरी, यहाँ पैसा है, पैसा है, पैसा है और कुछ नहीं है. ठीक है. वापस आ गया इंडिया 2005. Came back, told him, चलो लंच के लिए मिलते हैं. First lunch we meet. He's like, दीपक यार मैं वापस जा रहा हूँ. I was like, 2 साल I have been parroting this in my head. I come back here and now you tell me कि मैं वापस जा रहा हूँ. He's like, आज तेरे को पार्ट 2 बताता हूँ. इंडिया में तो पैसा भी नहीं है.
Right.
So yeah, that kind of encompasses the struggles when you come back. I think people find it very difficult to readjust here. That's why many people do want to come back, but eventually relocate again. It is tough. As somebody said, जो यहाँ है वहाँ नहीं है, वहाँ यहाँ नहीं है. Make your choice and be happy with it.
And cut ties with the other part.
Do cut ties. Yeah. If you keep your links, I think it's always tempted to get pulled. Or as you put it very well, there may be a small regret always in your life. But I think if you cut your ties, firmly plant your feet here, 20 years down the road, you'll be happy with your decision.
So before we finish it, sir, do you have an advice, as a general advice for, let's say, an intern comes up to you and asks you about his career? Do you have a general advice for him?
You need to first see if they want to settle in India or abroad. I think if they have a desire to settle abroad or they have the mindset, you know MBBS colleagues of yours sometimes from second year, they're like, we want.
Yeah, they know it. Yes. Yeah.
I strongly encourage that. I think if there is a mindset to go abroad, I'm like, take the USMLE, go. Life is good. You get trained, it's structured training, you'll get a good job, you'll have a decent life. You'll give up what you have in India, but professionally, you'll have a very good life. I think that's a separate filter. If you need to go abroad, I'm like, just go. Don't think about it. I think if you want to join a career here, then by and large, medicine is still a struggle in India. I mean, things are a lot better with many big hospitals, corporate, semi-corporate setups. Like job opportunities are better. But you think about it, if you want to settle in a big city, there are very few places of employment. It's not like working in a corporate job elsewhere. You can change cities, change companies. Within a city, you can change 8 companies, 10 companies in 20 years. That luxury is not there in medicine. If you want to live in a metro because there's better healthcare, better schools, etc., it's always a struggle. For those who come from a separate hometown, like a tier 2 city, my advice is train and go back to your city. You will, if you've trained well and you're good, you'll be kings in 5 years. You'll have the respect of society. You'll have a good practice. You'll have a great lifestyle. Life in the metros is fast-paced. We just don't have enough time for ourselves. You'll have a nice pace of life. And I strongly tell somebody, if you have a hometown and you have ties with it, go settle in your hometown. That's true for all fields of medicine, even head and neck surgery. You can, as long as you have a decent place to work that supports you with infrastructure, you can make, there is still a dearth of head and neck surgery in India. I mean, we know because we live in Delhi and we hear of so many surgeons here or Mumbai or etc. etc. But you think of all the smaller towns, tier 2 towns, there aren't dominant head and neck surgery units there. And the patient load is tremendous. If you're good, you'll make a tremendous name. We have so many trainees who've passed out with us. Those who've really chosen to move back with their hometowns have done really well. And fastly well. And very fast. Very quick. And it's really heartening to see that sometimes you do feel head neck is a tough profession to settle into because it takes years to build reputations. Years, decades to build a reputation. But it's so heartening to see them do so well 5 years out from training. Yeah, I think so. That's the other thing I tell them. If you have a hometown, always think of relocating there. Quality of metros are glamorous, but the quality of life of your hometown is the quality of life of your hometown. There is a charm to it. Maybe I'm getting old.
Sir, एक और question है sir. This just came right now in the top of my mind. I am also a surgeon, as you know, but I have never been involved in such long surgeries. Sir, how do you do it? Like, do you take breaks? Do you prepare yourself before? What is the mindset going into a 12-hour or 14-hour long surgery?
So you do take breaks. I think when you're training, you generally don't get a break. Lunch used to be at 7 p.m. in the evening. But of course, now you get breaks. And that's why you have to develop a team. So you can all work together. You, of course, want to be there for the critical, crucial parts of the operation. But there is part as a surgeon, opening, closing, exposure, where if you have trained good colleagues you're working with, you can share the workload for that. That's number one. To prepare for a big operation, and this I learned in my fellowship, is you need to break it down into parts. Once you break down, no matter how complex or a big operation, into parts, it's not that difficult. It could start with incision planning, could start with exposure. It could start with I'll mobilize structure A, then I'll mobilize structure B. Rather than seeing the whole thing as one big thing, like a journey, break it down into parts. No journey is long enough. And I think that's also a good way to approach the operation. So you're not sort of thinking 10 घंटे का operation, you're thinking 1 घंटे का ये section है, फिर 1 घंटे का ये section है, फिर 2 घंटे का ये section है. And you do it in parts. Having good colleagues is good. You can always talk through the operation. I always give the simile of driving with surgery. I do. I think they're very similar. A lot of driving happens subconsciously, but it's not like you're not focused. I mean, your hands are moving, your legs are moving, your gears are changing, your brakes, your indicator, you're using your headlights, flashing. You're doing 20 things, but you're doing them at a natural, subconscious pace. But you're completely aware of what's going on around you. You're analyzing variables all the time. Who's coming, who's passing, who's going there. And it's very similar with surgery. After some time, it becomes very subconscious, but you're completely aware of what's changing. And people said, you talk in surgery? Many non-doctors ask me. I was like, of course, it's like driving. I can talk when I'm driving. I can even have music playing when I'm driving.
And it sometimes you need to.
Sometimes you do. Yeah, sometimes you absolutely need to. And you're not peered into the patient for 12 hours. You will look up, take a break, maybe say 2 lines to the anesthetist or whatever. So I think 10, 12 hours seems like a lot. It's not that rough. I don't think it is. It's a skill you get very quickly. Like, it's not challenging at all. It takes just a couple of months and you get used to a 10, 12 hour operation.
Great. Well said, sir. And so that was a phenomenal interview with you. Thank you so much for coming to this podcast.
Yeah, my pleasure, Naman. It was great fun.
So guys, it was a great podcast with Dr. Deepak Sarin. If you liked it, and share it with your friends. Please comment what you liked and what can we do better. So thank you for watching.